Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
The JCO podcast provides observations and commentary on the JCO article, Cost Effectiveness Analysis of Monthly Zoledronic acid, ZA, every 3 months ZA, and monthly denosumab in women with breast cancer and skeletal metastases, CALGB 70604, Alliance by Shapiro et al. My name is Dominique Levesque, and I am a clinical pharmacist at the University Hospital of Strasbourg, France. My oncologic specialty is clinical pharmacology. As a pharmacist, I was interested in the promotion of generic drugs, but also in a positive view of off-label drug use. Off-label drug use, as well as generic drugs, are subject to controversies. In some circumstances, off-label drug use may be a valuable option, and regarding generics, they offer a cheaper option with the same quality as a brand-name drug. The study analyzes the cost-effectiveness of various schedules of bone-modifying agents in women with metastatic breast cancer. The less frequent administration of generic zoledronic acid every 3 months was the most valuable option. Bone-modifying agents, denosumab, zoledronic acid, pamidronate, are recommended in women with breast cancer and bone metastases. They are aimed to reduce the occurrence of bone-related events such as pain, hypercalcemia, pathologic fracture, and spinal cord compressions. Bone events occur in roughly 73% of patients with metastatic breast cancer. They affect the quality of life of patients and are costly in terms of prevention and treatment. Regarding the official labelings, denosumab, a receptor activator of nuclear factor kappa B ligand, referred as to rancor monoclonal antibody, is given subcutaneously at 120 milligrams every 4 weeks, while the biphosphonate zoledronic acid is administered intravenously at 4 milligrams every 4 weeks. Denosumab is the most recent agent and is costly. On the other hand, zoledronic acid is available as a cheaper generic. Both drugs are clinically comparable, and intuitively, generic zoledronic acid is the less costly option. Some authors go further. In a previous randomized study, the Cancer and Leukemia Group B, CALGB 70604 trial, the investigators showed that zoledronic acid given off-label every 3 months for 2 years was not inferior to the approved monthly schedule in a large population of 1,822 cancer patients with bone disease in terms of reductions of bone-related events. There was no difference of toxic effects in the 2 groups. When the optimal schedule of administrations are not known or have been arbitrarily defined, studies that test alternative options, low dosages or less frequent administrations, are very interesting. In a general way, given a similar efficacy, less intense regimens may be less toxic and are less costly and more convenient for patients. A similar approach has been used with glucarpidase, a very expensive enzyme given in case of methotrexate intoxications. A lower and cheaper dose was shown to be equivalent to the approved dosage. These examples illustrate the positive aspects regarding the cost of off-label drug use. I can also add the off-label use of bevacizumab instead of approved and more costly ranibizumab in ophthalmology. Following the CALGB 70604 trial, the investigators analyzed the cost-effectiveness of different schedules of bone-modifying agents, monthly denosumab, generic zoledronic acid monthly, and every 3 months. They tested the 3 treatments based on the Markov model in a hypothetical population of 10,000 patients with breast cancer and bone disease over a 2-year horizon. The monthly probabilities of first and subsequent bone events came from clinical trials, including the CALGB 70604 trial. It has to be said that no results regarding the comparison of the 3 options are available. The bone events include pathological bone fractures, radiation to the bone, surgery to the bone, and spinal cord compressions. The cost of treatment, denosumab and generic zoledronic acid, and the cost per bone-related event avoided were calculated from the 3 strategies from a U.S. payer perspective. A sensitivity analysis was also performed using various scenarios and including quality-adjusted life years, referred as to QALY, as outcome rather than the bone-related event avoided. Not surprisingly, the less frequent administration of generic zoledronic acid was far cheaper, 9-fold, than denosumab. The 3-month zoledronic acid strategy was the optimal treatment, assuming equivalent QALY for the 3 options. The sensitivity analysis did not modify the conclusions. The authors have very well discussed their results, highlighting the strengths and the weakness of their model. For example, the limited 2 years perspective in a disease where 34% of the patients live more than 5 years, the fact that subcutaneous denosumab is more convenient to administrate than intravenous zoledronic acid. Furthermore, the authors pointed out that their cost-effectiveness analysis was independent from the pharmaceutical industry. In pharmacoeconomic studies, manufacturers tend to favor their products over competitors or generics. Obviously, the cost analysis was performed in the U.S. health system and may not apply to other countries. For instance, in France as well as in other areas, the cost of drugs and those relative to bone-related events are different. Furthermore, in France, there is no out-of-pocket copayment for the patients, and cancer patients are fully covered for their treatment both in hospital and the ambulatory setting. However, it does not change the final conclusion, which is that generic zoledronic acid given every 3 months is a less costly strategy. In conclusion, this study promotes an intelligent off-label schedule coupled with the use of generics. This represents a convenient strategy for breast cancer patients with bone disease and a cheaper alternative both for payer and also for patients in case of copayment. This concludes the ICO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.